Neil, the American Heart Association Scientific Sessions here in Chicago is quickly wrapping up to a close. But it's been a great meeting. Northwestern has had a wonderful presence, and you really have been instrumental in bringing forward one of the most important, most newsworthy considerations, not just for the meeting, but for the practice of cardiovascular medicine. So first, congratulations.
Thanks, Clyde.
Now tell us, what's different about the new set of guidelines, and how does that build on 2013, which was very abrupt because a lot of things changed in 2013.
Exactly.
But now in 2018, it's like the train is moving. We've got momentum. We've got some great ideas. Talk to us about that.
Well, we've got new science. These new guidelines have given special consideration to secondary prevention. Before we talked about a maximally tolerated statin.
Right.
But now, due to these 3 large trials with non-statins, we're able to say that we can say that a threshold of 70 is evidence-based, and that if your patient who fits the very high-risk criteria, multiple major ischemic events or one major ischemic event and a lot of high-risk factors, then they deserve a non-statin to get the LDL below 70.
So just to be clear, that threshold you're talking about is the LDL of 70 milligrams per deciliter.
Right, or 2.3 millimoles per liter for our...
And so if we're talking about those risk enhancers, and I love that language you brought forward with risk enhancers, we see this all the time clinically, but we've wondered, what do you do with LP-A? What do you do with CRP? How do you navigate when there are these other things that seem to matter, but you're not quite sure how to factor them in? How did you bring these forward?
Well, so first of all, we took a hard look at people at borderline 5 to 7.5 or intermediate 7.5 to 20% risk. As you know, we've got an additional clinical trial that showed that statins provide benefit in primary prevention. But many people were not convinced by their number. And I think we thought a great part of it was that they didn't really see themselves as being at risk for coronary disease. Being at risk is more than major risk factors that give you a number. So we developed evidence-based factors such as an LDL more than 160, metabolic syndrome, so-called prediabetes, inflammatory diseases like rheumatoid arthritis or lupus.
LP-A.
Well, we'll get to that in a second.
Okay.
I'm going to hold off on LPA because I want to mention chronic kidney disease. We want to bring out those factors, and especially the family history of premature ASCVD and an LDL of greater than 160. Those factors are solid. If one has those factors, people really ought to be considered for statin therapy in a strong way.
Good point, good point.
But in addition, we said if measured, because not everybody needs them, you may want to consider an HSCRP, that's a marker of inflammatory disease, proven in some but not all trials to predict how people respond. 2, LP-A, especially if there's a strong family history of premature CAD. That's where that may be most useful. And then lastly, ApoB, and those with triglycerides 200 or more. So based on a strong history, basic exam, basic lab test, we know enhancing factors, and then if you happen to have available some of these additional ones, that could make your discussion more fruitful for the patient.
And now we enter the CAC score.
Yes, so think of it this way, there are 3 steps. 1, risk assessment with major risk factors. 2, enhancing factors. We're going to personalize the risk discussion. And 3, for those people who say, you know what, I still can't make a decision. I'm not sure this is for me. We know based on MESA and we know based on bioimage, 2 large observational studies, that a significant number of people may have a CAC score of 0. So if they don't have a family history that's strong, they're not diabetic, they're not a person who smokes cigarettes, then a CAC score of 0 would mean they could defer or postpone the decision for 5 or 10 years.
So what we're really talking about is a fundamentally important question in the office. When you believe that someone is at risk for atherosclerotic cardiovascular disease, when should you start a statin? We have the 2013 guidelines that talk to us about risk and having a shared decision-making conversation. And now Dr. Stone is telling us that we have more ammunition. we have better ways to referee that decision.
Yeah, and I want to bring out, I didn't mention among the enhancing factors, an exciting new addition. We took a hard look at what risk means to women. Too often physicians don't take an obstetric history. Have they had, for example, preeclampsia, which really ups the risk as time goes on for a woman who unfortunately had preeclampsia during her pregnancy. And also we took a look at early menopause. Did it occur for any reason before age 40? These are examples of two factors that should be included in the history of how we determine if she's at risk. And now that takes its place as an enhancing factor.
So that's really brilliant, because it's no longer about an increased LDL level. It's that plus. And you've been so clear to us to identify what that plus is. Now, we also heard about another data set here that we were stunned to see, but we're wondering, how do we deal with this clinically? Reduce it, suggesting that when we give fish oil for someone with high triglycerides, we might actually reduce the number of atherosclerotic events. Fact or fiction? What should we do with this information?
Well, I think we still need to study reduce it very carefully.
Okay.
Whenever we see a positive trial, we all get excited.
Right.
Absolutely. But we would have thought that because reduce it looked only at those with high triglycerides,
Right.
that the benefit would come from reducing triglycerides. It doesn't look at first glance like that's where the benefit was. We're a little unsure of why it benefited those in secondary prevention when added to a statin, or those with diabetes. I think we need to study that more carefully. That's not part of the guidelines because, of course, the results were just presented at these meetings. It's not published yet.
But there was even one other
It
fish
is
oil
published,
study.
but it's published as of now.
Right. But there was one other fish oil study that was negative.
Well, and that was a low-dose fish oil. So the guidance has been just taking a fish oil capsule a day. It really doesn't move the needle in terms of giving you a lower risk or higher risk. I tell people, if you can tolerate fish, have more fish in your diets.
Yeah.
Salmon's a wonderful choice. But the Reduce It study requires thoughtful consideration of how did they get the effect, what does the effect mean, and how are we going to use this in our practices?
So let's wrap up by talking about something that every doctor deals with on a regular basis. You've got a patient that comes in and says, my vitamin D level is low. I had a health screening assessment and I have a low vitamin D. Should I take vitamin D to reduce my burden of heart disease? We've got new data now. What should we tell the public?
Well, the study, the VITAL study, was an important study because it says taking either a fish oil capsule or a vitamin D. It was one of those studies where they had it all randomized, so people didn't know if they had a placebo or vitamin D or fish oil or a combination. And they were able to show that just giving a vitamin D to a large number of people, 27,000 people or so, giving fish oil, that one capsule didn't do the trick. It did not look at the fact that if they've had trouble taking a statin and have a low vitamin D, does vitamin D deficiency help the statin in patient with associated side effects do a better job? We want to revisit that more carefully. But the idea of just going to the store and grabbing a fish oil, grabbing a vitamin D, and saying, I can't take enough of these vitamins, we just don't have the evidence to show that A, C, D now, vitamin E, fish oil. Many years ago, more than 25 years ago, I was chairman of the nutrition committee of AHA, and I said, better off the plate than out of the bottle. I think VITAL still backs that up.
Great. So what we've talked about today is that there's no evidence to support exogenous vitamin use to lower the risk of heart disease. There's circumspect evidence, some positive, some negative, about fish oils, but there's overwhelming evidence to do what we've always known to do. First, lifestyle modification.
Absolutely.
Then a risk assessment.
Right.
Think about these risk enhancers. And then statin therapy where appropriate, and non-statin therapy if we don't get the threshold below 70. Any
for the highest risk people, right. For the highest risk.
So any additional wrap-ups for our audience?
Yeah, I just want to make that distinction, Clyde, because I don't want people to think 70 now is the goal for people in primary prevention.
Okay.
It's not. It's to get the right intensity of the statin still. One exception might be the one with familial hypercholesterolemia. Don't want to forget them because
Right.
we had special consideration for them again in these guidelines. They start the day LDLs 190 or more, early family history, early personal history of heart
Right.
disease. We can't get the LDL low enough, and they require intensive therapy, not just with a statin, but perhaps with a ezetimibe or even a PCSK9. And likewise, in that special group of secondary prevention at very high risk, maximal statin. If they're over 70, then ezetimibe, or if that's even not enough, of PCSK9.
Right. Neil, I want to thank you. I think
Thanks,
we've
Clyde.
given our audience incredible guidance on what to do today or tomorrow in the office about your patient at risk for atherosclerotic disease and how you can best modify that risk. Thanks so
Great.
much. It's been
Thanks
a
so
great
much.
showing for Northwestern here. And you've led the
Absolutely.
way. I appreciate that.
My pleasure.
Thanks so much.
Thanks.